This episode of the Senior Rehab Podcast is sponsored by the Academy of Geriatric Physical Therapy. AGPT's mission is to further your ability to provide best practice physical therapy and to advocate for optimal aging. One of their most popular articles published is Dale Aver's white paper on strength training for the older adult. You've likely heard us talk about this paper, but it is a fundamental piece of work that I highly encourage y'all to read. This paper covers proper dosage, how to set intensity, and how to get your patients strong. You can find this resource for free and much more over at geriatricspt.org/SRP. That's geriatricspt.org/SRP. Hit me.
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hey listeners, do you ever wonder who's actually behind all this research that we're promoting? Who's getting the evidence for our evidence-based practice? Well, today you get to meet one of those people.
Hi, I'm Allison Gustavson.
You're a physical therapist, correct? Practicing in geriatric setting.
Yeah.
Okay. Are you clinical at all, or are you solely into research?
I guess technically I'm full-time clinical researcher, but just the nature of my work, I also treat and do some outcomes assessments for patients.
How did you end up in geriatrics?
Yeah, so I actually, as an undergrad, did research in muscular dystrophy, and we did it in mouse models. And I ended up shadowing in the muscular dystrophy clinic, and I really liked that application between research and how to apply it clinically. So I applied to PT school thinking I was going to do some pediatric work, especially with kids who have muscular dystrophy. And then I ended up really gravitating towards the geriatric population. I had a really good SNF internship that I loved. And, you know, when I think about it, like the pediatrics and geriatrics are very similar in the fact that there's a very holistic approach. You have a lot of family involvement. You have cognitive impairments that can impact your communication with the patient. Like I said, you're really working on the basics of just how do you make this person function day to day and have a good quality of life. So that's kind of how I got into geriatrics. And
okay, I kind of love that it was a SNF rotation that got you into it, because like that's my thing. That's where I'm at. So this is really good.
Oh yeah, it was my first one, and I don't know, I just loved it. I also think it was my first exposure to older adults every single day. I don't know. Again, I really liked that we were just working on function, like we were involving family. We were trying to figure out the best plan for the patient to go home. And then I think I also just like the chaotic environment of the SNF. Like my schedule was crazy. It fell apart by the middle of the day, and you know, you're going to the bathroom 50 times a day, and you just never know what's going to happen. And I really liked that aspect of it, as well as like communicating with the interdisciplinary team, and again, just trying to find this plan for a patient who's had this adverse event and is almost in this crisis mode, and help them navigate and get through that. So
I think you just summed up like everything I love about the SNF and everything I feel about it. Like from the fact that it never goes as planned. Like I'll always joke, I'll get a schedule and I'll be like, I don't even know why I have this, because it's not going to work. Like I know going in, like that's not what my day is going to look like. But you know, the joke is at least you have like an idea of something that's going to fail.
Exactly. And I like the challenge of trying to figure that out. And it is frustrating at times, but makes my day go by fast. And like I said, I guess I like a challenge. Yeah. So then I worked full time actually in acute care, and then worked PRN in the SNF. But acute care is very similar in the fact that my day would fall apart by 8:30 in the morning, and you know, you just kind of be scrambling to figure it out.
So how did you go from full-time clinical? What made you decide to go back for your PhD? What in you said, like, I think I want to go back to pursuing research?
Again, I was mostly in acute care and skilled nursing facility settings. And when I was in acute care, actually my favorite floor was general medicine. So the gen med floor is pretty much your skilled nursing facility in the hospital. It was the same population. It was the population that was going to the SNF or home health anyway. And I was just kind of frustrated with the fact that there was really no evidence out there about how we should be treating both patient populations, these older adults, and everybody was kind of doing their own thing, and there was no kind of standard of care, a lot of variability, and that also created a little bit of conflict sometimes because people were doing different things. And when I went to the research, I mean, there's nothing really in, these acute populations who have experienced a significant decline in function and are in, again, this crisis mode. I kind of felt this need to kind of step back from the clinical realm and maybe help the profession in a different way. And in my mind, that was by going and establishing some of these clinical research guidelines and helping other clinicians navigate and bridge that gap between evidence-based practice and then what actually happens in practice.
Yeah.
Yes.
I don't know if the audience can't obviously see this, but I've been nodding the whole time you're talking.
Yeah.
Yes, yes, yes. It goes back to, I agreed with everything that you said about why that geriatrics is awesome and to why it's chaos and why we need the research. So.
Yeah. And I had a background in research. So I did a lot in undergrad, again, with mouse models, and then wanted the clinical application. So it wasn't that much of a leap. I'd already had this investigative mind and this just way of thinking that made me want to pursue research, and kind of having all these questions in clinic really solidified that pathway for me.
That's awesome. See, yeah, I look at the idea of research and I'm like, ugh, someone else can do that. I'll read it and I'll ask you questions, but okay. I don't want to actually do it.
Yeah. Well, and that's why I said there's not a lot of us out there that do. So I just felt that calling, and it's really needed. There has to be people that step back from that clinical realm in order to kind of advance the profession in a different way. And even now, I just really feel like that was the best decision for me, and that I've felt more fulfilled in the fact that I'm impacting the profession in a little bit different way.
So now, where are you working out of? Where are you doing your research from?
Yeah, so I'm at the University of Colorado, and it's actually in Aurora, Colorado, and it's on the Anschutz Medical Campus, which is just a health sciences graduate school campus. So I work with Dr. Jennifer Stevens-Lapsley, and so I'm doing my PhD in rehab science.
And how did you end up in Colorado?
So my mentor at the University of Minnesota, so Dr. Dawn Lau, she does, again, this research in kind of aging and muscle and kind of disease processes that impact strength. And she knew somebody out here, and we got connected. And then I talked to Jen at CSM. I think it was Vegas. Yep. And I talked with Jen, and really unique opportunity and good timing, because she is been traditionally in the total joint replacement world. And she was looking to branch out and kind of reach this post-acute care realm. And it also happened that Jason Falvey, who a lot of you know, was also applying to the program at the same time. And there's very few people out there that are interested in research that were in kind of these geriatric populations. So it just seemed like a really good opportunity, and she was willing to kind of take a chance on us pursuing this line of research. That's why and she's also a very skilled researcher and well-funded. So it worked out really well. And right now, me and Jason have really established this line of research, and it's really exciting kind of as we leave to see other people that are getting excited about geriatric research. And we have a couple of new people coming on that are going to take on that research and branch it different ways and really start growing our research in the geriatric post-acute care population.
I'll tell you, when I was talking to my coworkers about speaking with you tonight, they were excited for it. They were excited for the fact that I'm going to talk to you, and the fact that you're doing this work, because we have these conversations at work about norms and the data. And we're well, how does this apply to our population? How do we use some of these studies? What are we looking at? And, we're trying to piecemeal and figure out, okay, well, I'm modifying this. I got to document this, and how we're going to all modify it in a way that's consistent across our department, and what are other people doing? and I am a CI, so I'll have students, and I was taught, and I know a lot of them are taught, like, if you can't do something a certain way, you don't do it. Well, then I don't have any kind of data to put in my note, to put in my eval. So I'm like, you have to do something.
Yeah.
Pick something, modify it, document your modifications, and then just see how that plays out over the course of care. Like, a lot of times we're looking, can we get them to be able to take that test correctly? To do, like, can we get them to a 5-time sit to stand in a way that does give us normative data? Because
right.
We're starting with elevated mats and using your hands and all kinds of modifications, and we're trying to work towards just being able to do it, having the strength to perform it.
Yeah, a lot of my research looks at kind of change values, which allows for those modifications as long as you do it the exact same way at evaluation and discharge.
Mm-hmm.
It is tricky, and that's why I say I think we need more researchers in this area, because I think the greater, other physical therapy research doesn't have to deal with some of the issues that are inherent to the geriatric population. Like you said, there's a lot of normative data for like community dwelling older adults, not for the ones that we might be dealing with. There's more research on frailty that's coming out, but again, it's so much, it's almost like, how do you synthesize and make it work for the patient in front of you? So a lot of my research, again, is like creating tools and pathways to help the therapist treat that individual patient in front of you. Because again, all this research takes these mass populations and large data sets and looks at factors that might impact research, or uses a large data set to create normative values. But again, how does that help me for the individual patient in front of me is kind of what I'm working towards too.
So let's talk a little bit more specifically about your working on. Tell me about like what you're looking at, how you're setting it up to take like those big groups and that large amount of emerging data, and how are you bringing that to like a clinical perspective?
The premise of my dissertation work is really implementing high intensity interventions in the skilled nursing facility setting. And then I also help with a similar kind of approach in the home health setting. While we know from Fiaterone, and obviously the senior rehab group knows that high intensity is possible and is effective for older adults, it's just not implemented in practice. So pretty much like a little part of my research is looking at the actual effectiveness in this post-acute population, because again, we don't really know when they have a severe functional decline. We know in like functionally stable populations, we see the effect. But then a larger part of my research is really on how do I apply that in the context of a skilled nursing facility setting? Because even though therapists know that they should be doing it, it's not being done. And I don't think it's not being done because they don't want to or don't believe in it. It's just, again, how do I make it work in the SNF setting? And then from a research standpoint, how do I make that systematic so that we can go out to like on a large scale and have people replicate it and be successful with implementing it? So that's my dissertation work. I work on a few other projects as well, but it's all about creating this cultural change within skilled nursing facilities. I work a lot with other teams, including nursing and guest services and the physician groups, to create this overall culture. Because again, a lot of times what we do in therapy isn't always impacted by what we believe and what we, I saw hands up, but we have these external factors that are happening outside of our realm in the physical therapy that are impacting our care. I guess the example I always think of is we could provide the best physical therapy in the world, but patients only see us for 1 to 2 hours a day. So what are they doing the rest of the 22 hours? And I think, well, I don't have exact data, but I think we all know that those patients are sitting or lying in bed. So how do we engage other teams, and how do we kind of be innovative and think differently about how to use some of our other providers to help with that physical activity? Because we're sending patient's home, yet they've been like laying around all day. But now all of a sudden they have to make their meals instead of like the meal just coming to them and the meal being taken away. And how do we help patients be better prepared to go home? And that might be thinking differently about how we utilize other teams and how we communicate with other teams, because they really rely on us for the expertise in how to transfer, in what we prescribe. Like, yes, this patient should be doing walk to dine and, having that communication. And that's kind of probably my life's work. It sounds really easy, but it's very difficult.
About implementing a walk to dine program sounds easy. Like, I don't think anyone who's ever tried to implement one or carry one, and I don't think anyone thinks a walk to dine program is easy to implement. Like,
right. That's hard. And then, like I said, I'm trying to add other pieces of like beyond that, also engaging the patient a little bit more and having that accountability. And there's, different approaches to it, but a lot of what I do is kind of processes and working with the healthcare systems to see what works best for them. Because the biggest barrier is communication between teams. So again, this sounds really easy, but when you actually do it in the SNF, just to have a walk to dine program, which in my ideal world, I would imagine something even bigger where you may be doing restorative care, but just the walk to dine, you have to coordinate and make sure therapy coordinates with nursing to make sure that, they know what type of assist they need and all that. Most SNFs operate off 2 EMRs. So you can't talk directly to the nurse via the EMR. Yep. So then you rely on this, like, just talking to them and hoping that they hand it off to the next person because they're not going to be there the next day and they're not there for the night shift. So you have all these like breakdowns in communication with just doing the walk to dine program. So what happens is people just don't do it because it's a safety issue. There's too many breakdowns in the communication. And then you have the patient. Again, if you don't set that expectation that you actually do need to walk to dine, well, the patient's going to, maybe tell you no if they don't understand the purpose. Mm-hmm. But, that has to come from the therapist, but it also has to come from the other teams. Like if they're constantly getting this message that I need to be working on my rehab outside of rehab, then we have a better chance of kind of engaging them or engaging family for those who maybe have some cognitive impairments. I think that's another, item we could do better. But again, we don't really have that in place right now. And part of that's because we haven't really talked to other teams and figured out some of these more like logistical issues, and the 2 EMRs being a very difficult.
I love that you brought up the 2 EMR thing because that is such a struggle that like I personally have, and I know that like the rest of my rehab team has. Like we have to document in different places for the same thing. And it's like, okay, you're putting this here, but then you're going into this other system and you're clicking like on all these things and you got to make sure everything matches up. And there's like 7 things you have to do just to get somebody like on a ambulation program that when it gets messed up, which it invariably does, it's like, it's so frustrating because you're like, I'm spending all this extra time, still not effective because we're still not communicating well.
Yeah, I have a lot of issues with the 2 EMRs for that reason. I mean, again, like if you look at a medical EMR for the SNFs, like they'll have updates on who had a fall, who has a pressure ulcer and stuff like that. And you're just hoping that the nurse catches you before you go into that room to tell you critical lab values, where they can just look at it and see it and be like, oh, well, yeah, Mrs. Johnson has a critical hemoglobin value, but you don't see that. So you just,
when you get the phone call a half an hour after you bring them back to their room and they're like, oh, by the way, so-and-so.
Yeah.
And you're like, it's too late.
Yeah. Or like you work with somebody and then you go back later and you're like, wow, they were really off today. Like, and then they go, oh, they have a critical hemoglobin.
Yeah.
So I don't think, and again, like it's a communication thing that it's not the nurses that don't want to tell you. It's just, they're kind of doing their own thing and they don't realize you don't have access to that. So it's just a huge barrier. And then on the flip side, they don't have access to our notes either. So they can't, because a lot of times we're the people that maybe catch things or are making decisions. And a lot of times the doctor doesn't even know like what we're recommending for discharge, because they don't have that quick access to kind of see what we were thinking or, what we've been working on. Because again, like if you want to think about the patient experience, patients have better experiences when they have continuity of care. But when the doctor doesn't know what therapy is doing and, and they're getting different messages from people, well, that makes patients kind of shut down in engagement, and it also makes their experience a lot worse. So again, improving quality of care and interdisciplinary communication can also improve the patient experience, which could also, increase patient engagement in their own recovery. So I think like we could by solving one problem, we could kind of get solutions to a number of things. I'm all about efficiency in that matter, but I'm still trying to figure out how to address that.
Oh, I think you've given us a lot of hope, because we're like, oh God, someone is noticing this and someone is looking at it.
Yeah.
Like a lot of the frustrations people have, like you've talked about it and you're bringing that to the surface. And I think that it's frustrating for some therapists to be in the SNF, because we understand why we're there, right? We come in looking to help these older adults. We come in looking to help people go home, to take that holistic view of care and, make people safe. And then there's so many things that kind of like beat us down in the day-to-day. You have to appreciate a certain level of chaos to work.
Yes.
You have to be able to work efficiently, or even just appreciate other people coming in and out, and be able to like bounce through a session where maybe you're doing something and then a doctor comes in, or they have to stop, or you have to be able to appreciate that and be able to work with that and know that your plans are going to change, and you're probably going to have EMR problems, and there's something that you're going to have to leave the gym and like run down the hall and talk to the nurses about. And I think for some people, they really want to do the evidence-based care. They really want to do what they can, but there's so much in the system that just kind of beats down on us. The fact that people are looking at the system and how we can make it better, and how we can really focus more on our skills and help the patients, like their experience, their rehab. I think it's going to give people a lot of hope, honestly.
Yeah, well, I'm hoping so.
Where do you see this going? You're saying that you're finishing up?
Yeah, so I'm supposed to finish up either late fall or early spring. And I think really the field's wide open. Again, not a lot of people do research in this area, but it's kind of a hot topic. As many of you know, the payment system is set to change in 2018, and then there's other changes coming in 2019. And I think there's a lot that we can still do to prepare ourselves. One, I think we need to make sure we assert our value in skilled nursing facility care. I know it sounds obvious, but we have to be thinking that at some point we could be going to a cost center like therapy does in acute care, where they value PT in acute care, so they will pay for it. There is a chance that could happen in a SNF. So how do we make sure that we are prepared with data that says we are actually worth keeping on, versus like maybe they could get restorative care, and they have one PT that runs a restorative care team. I don't want to give people ideas, but but realistically,
that someone has thought of this. Like, it's come out of someone's mouth in conversation. So I don't think.
Right. Well, and we just have to think again, and a lot of times, again, we know what we do and we know what we do is important, but we need researchers to kind of translate that and show that data and interpret it for, health policy types of research, because a lot of times if you look at the data, because the variability in care is a huge issue, because what that does is that makes it look like we have no effect. Again, part of my work is standardizing it a little bit. And I know therapists get nervous about standardization, but it's kind of standardizing certain kind of core elements, and then you can adapt it to the individual patient. But right now we don't have any of that. And part of it's because we don't have any clinical guidelines for this population. And then also, we hadn't traditionally, now the payment system's changing where we have to report standardized functional outcomes. Mm-hmm. But the thing is, we don't know what to do with that data or how to interpret it. And I think we're the best people to interpret that data because we're the experts on it. Me and Jason Falvey are working on how to interpret that data and show our value, because that data has now been accumulating, and it'll just get more as people have to standardize in order to get paid. Yeah, there's just a lot of different avenues to pursue, especially with this onset of the changes. So I kind of rambled, but basically my goal is to really assert our value in post-acute care and make sure that we continue to assert that value as the payment model changes. And I think we have to be realistic that our approaches to therapy will need to change with reimbursement a little bit, and we just have to be more effective. So, for example, we are not going to be able to get more therapy minutes or longer length of stay. Like, that ship has sailed. Like, they're reducing those. So we need to think, okay, well, they're reducing those. We have to deal with that. What can we do to be more efficient in a shorter period of time? Or how can we use data to then, when we discharge the patient, to make sure that they have the appropriate services, because we can use functional data to identify them as a high-risk population for adverse events. And that's something that we just need to be aware of, that as the system changes, we have to change along with it, and just kind of being ready and anticipating that a little bit, so that we make sure we're still value providers in post-acute care. The other issue is that it'll be very interesting to see this roll out, because we are getting more acute patients. We've said this every year, but especially with the onset of bundled payment systems, we used to see a lot of patients post TKA and THA. Now you maybe see one, a month. That means you're not seeing, and let's be honest, we all love our total joint because they're kind of easy. They're in and out in a week. They also have an elective surgery as opposed to a crises event. So they're a different patient population. But now they're not in the SNFs anymore unless they have some serious problems. Then they go to the SNF. So, and that's the way hospitals are really going now. If that person really can't go home, there's no way, then they'll go to the SNF. But that means we're getting a very medically complex acute population. So it will be interesting. And I think, again, we just need to think as a profession how we can be creative with using other resources to make sure that we're setting the patient up, make sure that we are documenting well, and that we're taking standardized measures that can give other disciplines information about the risk of these patient populations. Because again, they're going to take payment, but they also listen to data too. If we can show that we can improve patients if we have a few more days. Like I said, I don't think they're going to give us a ton. Again, the more we kind of standardize our care, and payers know what to expect from PT, patients know what to expect, the greater likelihood we're going to have better outcomes, and that respect from people who maybe don't understand exactly what we do, which is a lot of people. So we've never had where we have this group of people that can come together. And I think that's really powerful, whether or not you're a researcher or a clinician. So I really rely on clinician input to help kind of, drive my research ideas and implementation in ways that I adjust it. And then I use my research skills to kind of help clinicians, navigate what they're doing and apply evidence to practice. So I really like that there's a large group that are passionate about that, and that we can kind of get different perspectives and help each other kind of advance this profession, especially given that SNFs therapists have traditionally not gotten a lot of attention. Whenever I say I'm a physical therapist, the first thing people always say is they're like, oh, my shoulder hurts. And I'm like, I don't do that kind of therapy. Like they don't have this understanding of what, maybe other therapists and subspecialties work. So it's kind of nice to have that group, especially since definitely our orthopedic colleagues are much further ahead in terms of research and clinical guidelines and algorithms compared to the geriatric piece. And like I said, the more momentum we have, the faster we can translate that evidence into practice and really start making a difference.
Yeah, no, and like I said earlier, I feel like just knowing that there's people out there and that momentum is building, like it gives other clinicians hope. Like the clinicians who are like deep in it and just trying to get like stuff done and just trying to deal and kind of getting kicked around by the system a bit. I feel like letting people know that like there's a lot that we're working on, there's a lot that we're doing, and there's so many options for you. I think that's going to be a big help. And the fact that we can now see some things on the horizon that you're working on, I think will be really great too.
I'd love to hear your guys' feedback too on ways that we can improve, because I think it's definitely, I learned from you guys, you learned from me type of relationship, especially since I've been in, I think SNF practice varies by geographical location, by different facility types, by different corporations sites, and I don't have all that insight. I just have like the ones that I've been at and the geographical areas that I've been at. But I think if we want to think about scalability on a nationwide level, I'm going to need input from a lot of different people, especially PTAs as well. That's definitely a profession that I don't think I have had as much feedback, and I think I need their feedback because I'm not a PTA. Like I don't know what kind of education they get, what kind of barriers are specific to them. Like I said, I really feel like that collaboration is what will drive it forward.
And I know like you and I have been kicking around the idea of getting you back on with maybe a group of clinicians to let all of us have kind of that Q&A experience. And that's something that we'll work on setting up and getting the ball rolling on. Kind of data should we be collecting in the clinic? At least
one of the same measures across everybody. And then, like I said, you can be creative, whether you think, the Berg would also be good for this patient population. That's where you can tailor it a little bit. But if you have a core standardized measure that you can use across your facility, and then that you consistently do at evaluation and discharge, like that's going to give us a lot of data, and it gives us across the population instead of like, oh, well, we only do that on certain patients. I would say that's probably the most important thing now. You have to train on reliability. Yes, those would be the two big things right now that I can think of. And I think the next step in the next couple of years is finding a way to partner and disseminate on a large scale. Yeah, we're definitely always looking for partners and, either different corporations or people that are interested in, helping us develop something that can be launched on a nationwide level. And
Allison, I just wanted to thank you for agreeing to talk to me. I feel like this was definitely something that like clinicians are going to want to hear. I feel like that it's inspiring, the fact that people are actually listening to what we're saying and are taking us seriously and hearing what we're saying. And I think that gives a lot of people like hope and a place to start. And I can only hope that it brings us further forward. It helps us understand our worth. It helps, the patients and the public understand our worth. You and I had a little sidebar about, getting the patients to appreciate us and not dread coming there and not being so afraid of it. And I really hope things like this do lead us in that direction.
Yeah, well, thank you for having me. And I'm really excited to kind of maybe get together with the Game Changers and hear your input and maybe help kind of drive this research forward in a collaborative way. And I don't know, maybe in a year I can finally reveal my dissertation results.
Best of luck, Allison, with your research. And if you would like to be included in that further conversation with Allison, I'd encourage you to come on and check out the Game Changers. You can find out more at seniorrehabproject.com. There are Patreons. They're the ones who help us keep this podcast going, help us get this content out to you guys. We'd love to have you. We'd love to learn more about you. So take a look, seniorrehabproject.com. Thanks again for listening.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.